Hello everyone and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator, Jennifer Zelmer, President and CEO of CFHI. Please go ahead.
Thanks so much, and hello and welcome to everyone participating in today's webinar, focusing on what we've learned so far from the COVID-19 outbreak in Loche, Saskatchewan. Une petite note, c'est que l'audio en français aujourd'hui sera diffusé par téléphone. Si vous voulez changer à cet audio, veuillez appeler le numéro sur l'écran. I want to begin this webinar by acknowledging that we're meeting on land that has been inhabited by Indigenous people since the beginning. In particular, I and many of my colleagues today at CFHI are broadcasting this webinar from Ottawa, the traditional unceded territory of the Algonquin and Anishinaabe people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. And as we gather, I would also like to recognize the northern village of Loche and the Clearwater River Dene Nation, which is located on Treaty 8 territory, as well as the homeland of the Métis Local 39. We feel so honored to have had members from the community helping to shape today's panel, including Chief Teddy Clark, Chief of the Clearwater River Dene Nation, and Robert St-Pierre, Mayor of Loche. Also joining us on today's panel, Leonard Mongrain, Area Director of the Métis Nation of Saskatchewan, Rim Zayed and Moliahi Kaketla, both medical health officers with the Northern Population Health Unit, Namdi Nudubuka, medical health officer with the Northern Intertribal Health Authority, James Irvine, consultant medical health officer with the Northern Population Health Unit, someone who shares the same first name as me, Jennifer Ahenakiu, Executive Director of Primary Health Care for the Saskatchewan Health Authority, and Brian Quinn, Nurse Senior Epidemiologist, Northern Population Health Unit. And so glad as well that so many people, hundreds of people in fact, signed up for today's webinar and are participating. And that is one of the wonderful luxuries that we have in this world, to be able to gather so many people virtually. But it does make it challenging to make sure that everyone has a voice in the conversation. So I would encourage you to introduce yourself in the chat so everyone knows who's on the call, and feel free to ask questions or share resources at any point throughout the call. My colleague Christine Quinn will be moderating a Q&A with our panel after the end of the formal panel presentation. As we begin, I'd also like to acknowledge that June is National Indigenous History Month, a month that includes both June 3rd, which marked the one-year anniversary of the release of the Missing and Murdered Indigenous Women and Girls Report, and the 21st, National Indigenous Peoples Day. In this month and every month, it's important to reflect on, honor, and learn the history, the sacrifices, the cultures, the contributions, and the strength of First Nations, Inuit, and Métis peoples. Also an opportunity to recognize the strength of present First Day communities, and we feel so fortunate to have members of communities with us today who will be sharing their story of resiliency and strength. One final housekeeping note from me before I hand it over to Jennifer to get started. Please note that the time for today's webinar has been extended to 75 minutes. A recorded version will be sent to all registrants in the few days following this webinar. So if you have to drop off right at 60 minutes, you'll still have access to the information discussed. Thank you again so much for joining us today. And Jennifer, it's my pleasure to hand it over to you.
Good morning, and thank you, Jennifer, for the wonderful introduction. We're very much looking forward to sharing our story of resiliency and teamwork in an outbreak related to COVID. So we're pleased to share our Northwest North Outbreak Lessons Learned presentation with a number of great panelists. So I'd like to begin by sharing a bit of information about the Saskatchewan Health Authority. The SHA is the single health region of the province of Saskatchewan. It is a health authority providing direct and contracted health services, including primary, secondary, tertiary, and home and community care, mental health services, population and preventative health, and addiction services to the people of Saskatchewan. As many of you may be aware, it was officially established on December 4th, 2017, and at that time it involved amalgamating the 12 regional health authorities that previously operated in the province. The SHA aims to position itself as a high performer and leader across the country in patient and family-centered care. And as a health system, we are committed to better health, better care, better value, and better teams for all residents of Saskatchewan. Our vision is healthy people, healthy Saskatchewan. Our mission is we work together to improve our health and well-being every day for everyone. And our values that were developed in a very consultative process with over 5,000 stakeholders from across Saskatchewan were our safety, be aware, a commitment to physical, psychological, social, and cultural and environmental safety every day for everyone. Accountability, be responsible, own each action and decision, be transparent, and have the courage to speak up. And that was very important as part of our outbreak response in the Northwest. Respect, be kind, honor diversity with dignity and empathy. Value each person as an individual. Collaboration, be better together, which I really believe we identify through this presentation by working collaboratively with many partners and community partners as well. And this includes and acknowledge the contributions of all employees, physicians, patients, families, and parents, as well compassion, be caring, practice empathy, listen actively to understand each other's experiences. And all of these values shape or provide the foundation of our philosophy of care within the SHA, which is our commitment to a philosophy of patient and family-centered care is at the heart of everything we do and provides the foundation of our values. With that, I'm going to turn the presentation over to Dr. Teketla.
Thank you, Jennifer. Our presentation today is going to be divided into three main parts. In the first part, we'll be providing the background to help a very broad audience understand the context in which the outbreak that we're being described today occurred. And then we're going to focus on the description of the outbreak and the response measures. And then finally, we'll be reflecting on the lessons that we've learned and continue to learn from this experience. As a panel represented today, we're all proud residents of Northern Saskatchewan. We live in and work with communities in the north where the experiences that we're going to be talking about today have taken place. The northern village of Loche and Clearwater River Dene Nation are communities located within the northwest part of Saskatchewan and within what has been referred to over the years as the Northern Saskatchewan Administrative District. It is a very beautiful part of our country that is characterized by forests, waterways, and the boreal shield covering the geographic half of the province. We work across several jurisdictions and through community partnerships to serve a culturally diverse population of more than 40,000 within that area, across 70 communities on and off reserve. It is in that context that just over 2 months ago, these two closely knit communities came together, showing tremendous strength and resilience to respond to the unprecedented COVID-19 outbreak that descended upon them. Mayor St. Pierre and Chief Teddy Clark will introduce us to their respective communities of La Loche and Clearwater River Dene Nation. Mayor, the floor is yours.
Thank you, Doran. Thank you for the opportunity. La Loche, Saskatchewan was incorporated as a northern village in 1983 with a population of around just over 2,800 people. The northern village of La Loche lies on the eastern shore of Lac La Loche in northwestern Saskatchewan near the Saskatchewan-Alberta border. The settlement of La Loche dates back to at least the fur trade and Peter Pond's discovery in 1778 of the Portage La Loche or Methe Portage, which crosses the height of land between the Hudson Bay and the Arctic Ocean drainage basins. The Methe Portage played a significant role in the Canadian economy. As a result of this, the people of La Loche have experienced a long history of colonization that resulted in intergenerational trauma, which is still felt today and exhibited in the higher rates of mental health and substance use in the community. And some of that can be attributed to residential schools too. So Teddy's not with us today. He sends his regrets. However, Leonard will speak to CRDN. Go ahead, Leonard.
Leonard, you might be on mute.
I'm bad for mute. Sorry about that.
We've all done it. No worries.
Okay, Tanse Atlanite. I just want to say hi to everyone out there. It's a pleasure of mine to be able to speak in regards to CRDN. I am not treating myself. I am Métis, but my wife and my children are treated from the Clearwater River Dene Nation. I just got to find the slide here. Sorry. So bordering Loche to the north and reached via Highway 155. 955 is the Dene Nation, Clearwater River Dene Nation, a population of 1,039 people who live on the reserve. And the Loche CRDN Population Center. Oh, jeez, I'm getting a call here. Sorry, guys. Sorry, I'm on my phone. That's why I'm having a tough time here trying to read it. The Loche CRDN Population Center with about 4,000 people represent 30% of the Dene speakers of, of Canada. The Dene language is spoken by 89% of the residents. Originally from Fort McMurray area people, that's Janvier, and our treaty was signed. Oh my goodness, I'm having a tough time with my phone here. Sorry, guys. Just cutting off on me. Just give me a second.
Not a problem. We can hear you well.
Okay. It's hard on my phone here. I should have been at on the computer doing this. Just give me a second. I lost the whole files. Well, for sure we're going to take up 75 minutes at the rate I'm going.
All good.
Yeah, it's back on now. Okay.
Wonders of technology. When it works really well. When it doesn't, we have to deal.
That's what it's done now. Originally from Fort McMurray area, that's the Janvier area. People in our treaty was signed in Fort McMurray in 1899. Back then, people migrated along the Clearwater River, Christina River to Garson Lake and to Loche. CRDN didn't receive its land until 1970. It was known as Port of the Loche Band. Later, the name was changed to Big C Band. And after years of negotiations to do a land transfer to be closer to the modern amenities, in the early 1990s, the band's name was changed to Clearwater River Dene Nation, which really represents our history. Thank you.
In Canada, northern Saskatchewan communities have very high rates of self-reported Indigenous identity. Specifically in the Loche, about 50% self-identify as Métis and about 46% identify as First Nation, whereas the Clearwater First Nation reports close to about 98% Indigenous. When we look at the social determinants of health, we see very similar trends when we look at education, employment, and income. In this particular slide, we're looking at the median income levels, and we can see that the communities of Loche and Clearwater are approximately 40 to 60% lower than the province as a whole, which is very similar to the Canadian rate. Another important factor when we're dealing with a respiratory disease like COVID that really spreads through close contact is housing. This particular chart is illustrating the rate of crowding, or the number of households with more than one person per room, and it highlights that the rates in the Loche and Clearwater communities are about 5 to 10 times that of the province. And another thing, whenever we're looking at communities that are struggling with the social determinants of health and have that history of intergenerational trauma and colonization, it's not surprising that we see challenges with mental health and addictions. This particular slide is looking at hospitalizations that are solely caused by alcohol, and it's important to note that this particular indicator is only capturing those hospitalizations, which only represent about 30% of all the hospitalizations that are caused by alcohol. Even still, whenever we look at it, we can see that the area in the northwest here has about a rate that's about 3 to 4 times that of the province as a whole and Canada.
And was the hub of our testing and mobile testing and everything. So it was integral to our response. The Loche Health Center has 9 beds in acute care, 5 long-term care beds, and 2 alternate level of care beds. The emergency room runs 24/7 with emergency medical services and emergency air medevac and ground transport. Even prior to COVID, it was a very, very busy emergency room and continues to be. Another unique aspect of the services in Loche is that our physician services are provided by Northern Medical Services, who contracts 9 physicians, covering 3.5 full-time equivalents. However, it's at 4 full-time equivalents during the COVID-19 pandemic. NMS also coordinates the delivery of specialist services to the community of Loche and CRDN and surrounding area through remote and in-person consultations. So just to give you some context, we have about 80 employees, both full-time and part-time. So that's significant when we look at the long-term care outbreak. Thank you. I guess I'm next. I want to share some information on Saskatchewan's response to COVID-19. On March 3rd, 2020, the Ministry of Health activated a Health Emergency Operations Center. And on March 5th, the Saskatchewan Health Authority convened a provincial COVID-19 planning meeting to formalize operational response plans for potential COVID-19 cases in Saskatchewan. And the SHA activated their Emergency Operations Center on March 9th. And following the creation of the SHA EOC, we saw a movement to integrated health incident command centers, which allowed for localized response with some provincial support from the Health EOC and the SHA EOC. So it was a cascading command structure that was implemented in response to COVID in Saskatchewan. As I mentioned, the Saskatchewan government had a Provincial Emergency Operations Center, which had multiple ministries represented. And so the Provincial Emergency Operations Center is established when emergencies begin to escalate beyond the capacity of a local jurisdiction or in a number of jurisdictions. The EOC was activated at that time in response to COVID, and it remained operational 24 hours a day throughout the emergency. All of the EOCs did, in fact. And this approach was utilized because it gave us an opportunity for one voice for communities needing help, and that was significant. Their supports and intervention, for the COVID outbreak in Loche and CRDN was critical. Then we saw the Health Emergency Operations Center that was located in the Ministry of Health. And underneath that, we're actually missing a box, was the actual SHA EOC, Emergency Operations Center. So the SHA Executive Leadership Team delegated decision-making authority to the SHA EOC for COVID-19 related response, as well allowed for engagement with the Executive Leadership Team when there was implications provincially and specific in areas. So the SHA EOC was the provincial decision-making authority for the COVID response. There was daily EOC huddles held throughout the Cascade. As well, it allowed for matters that needed to be escalated to the Health Emergency Operations Centers for any decisions, additional resources, or equipment support that were needed. And then underneath this, you'll see there's 4 integrated health incident command centers, and they were also implemented to support local responses to the pandemic. The IHICS decision-making authority applied to its specific integrated areas and was able to make decisions while executing approved plans or SHA EOC direction unless provincial implications were anticipated. There were 4 integrated health incident command centers established, one for rural, north, Saskatoon, and Regina service areas. And our commanders linked to the operations chiefs at the SHA EOC, and also represented the IHICs at the SHA EOC on daily operational huddles. And it gave us the opportunity to align as much as possible with existing structures to support integration with ongoing operations. And the SHA EOC was the committee within the SHA who was doing the high-level pandemic planning. There was also 15 provincial annexes developed for pandemic preparedness in Saskatchewan, which included health emergency management, continuity of health and surge capacity, finance, surveillance during pandemic, the Roy Romano Provincial Lab, infection prevention and control, public health, assessment sites, clinical guidelines for COVID-19, occupational health and safety, First Nations and Métis health, communications, continuing care, and mental health. The cascading command structure allowed for centralized points of coordination, command, and control of the SHA response. It also coordinated planning operations, allowed for a single point of coordination with the Ministry of Health, as well as timely SHA COVID decision making. However, the EOC IHIC structures were created to manage a time-limited system-wide emergency response to the pandemic. So with planning complete, the SHA is now shifting to a COVID-19 response function organizationally or operationally within the SHA management system. One of the really good key learnings of from the EOCs and the IHICs was the development of in-a-box resources available as needed. For example, healthcare, when the healthcare system is overloaded, such as acute care surge capacity, there's also an outbreak in a box that has been developed and can be implemented in different areas across the Saskatchewan Health Authority as required or needed. I'll turn the floor over to Mayor St. Pierre.
Hello. In mid-March, Mayor and Council decided that to combat this threat, it was crucial to be proactive and develop our own pandemic plan. Got in touch with CRDN Chief Teddy Clark, MNS Area Northern Region 2 Area Director Leonard Mogran to establish local leadership. We understood that this partnership was needed. We invited key community members from both communities to participate. After the pandemic plan was developed, it became clear we needed to follow up with a local EOC, Emergency Operations Center, to carry out the leadership objectives. Martha Morin was hired to oversee her staff, payroll, security for checkpoints, curfew, isolation units, homelessness shelter. She organized Meals on Wheels, donations, and distribution of the influx of items. Martha also developed a Northern Village Loche and CRDN COVID-19 update Facebook page to provide daily and factual up-to-date information. We had daily communications with health and translated in Dene by Randy Herman, aired on our local radio station. Thanks.
Thank you, Mayor. So from the public health side, our response both on and off reserve was coordinated through close collaboration between the Northern Saskatchewan Population Health Unit, off reserve, and our counterparts at Northern Intertribal Health Authority on reserve. Our Population Health Unit is a unique collaborative initiative in the province of Saskatchewan. We were established just over 20 years ago now, and at the time it was a way of sharing resources and expertise amongst what was then our 3 northern health authorities that were separate at the time. We are a multidisciplinary team of public and population health specialists that lead and support various programs across northern communities, working very closely with our community partners. As part of this presentation, we have medical health officers and an epidemiologist on the panel, but we're just a small part of a larger team that has worked diligently over the years to help protect and enhance the health of Northern Saskatchewan residents in various areas that include health protection, health promotion, disease surveillance, and disease control. Given the connections that our communities have, a long-standing cooperative relationship with our counterparts at Northern Intertribal Health Authority remains amongst our most valued. Dr. Ndibuka, over to you.
Dr. Kaketla. Hello, everyone. I respectfully acknowledge that I'm presenting from Treaty 6 territory today, the traditional territory of the Cree people and the homeland of the Métis. The Northern Intertribal Health Authority is the only First Nation organization of its kind in Canada. It is comprised of 4 main partners, namely Prince Albert Grand Council, the Middle Lake Tribal Council, Peter Ballantyne Cree Nation, and the Lac La Ronge Indian Band, and each has extensive experience in health service delivery. The partners formally joined together in 1998 to create NITHA. We deliver third-level services to 33 all-reserve First Nation communities across northern Saskatchewan, covering a population of about 37,000. This includes Clearwater River Dene Nation. We deliver public health services and nursing services directly to second-level partners in the areas of disease surveillance, communicable disease control, health status monitoring, specialized program support, research, planning, training, and technical support. Our vision is that partner communities will achieve improved quality health and well-being, with community members empowered to be responsible for their health. As part of the NITHA COVID-19 pandemic response, we activated an emergency operations center on March 24th to coordinate planning and response within the partnership. Community pandemic teams had direct link to the NITHA Emergency Operations Center. Thank you.
Good afternoon. Good afternoon, everyone. This is Dr. Zayed. It is my pleasure and the pleasure of my team to share with you our outbreak story. Our first case was diagnosed on April 15. Investigations led to link this case to Kerr Lake oil sands outbreak in northern Alberta. The index case was linked to a healthcare worker, which led to the spread of infection in the long-term care. An outbreak was declared on April 17 after the confirmation of transmission in long-term care. Next. The impact was severe on work capacity as 21 healthcare workers were put on self-isolation. 2 healthcare workers and 3 residents, as you can see in the Epicurve, were infected. A series of public health measures have been put in place. First is change in policy of staff daily screening. Residents are on contact and droplet plus precautions. Alert to atypical symptoms in elderly population was very important. Continuous communication with families at the visits as in everywhere else were banned. Mental health support for staff and residents, supporting residents by window visits and ITABs for FaceTime with their families, infection control and health inspection audits. We declared the outbreak over on May 15 with confirmation that there is no continuous transmission. The attack rate was 33% among residents, 8% among staff, and 16% overall in the facility. The milestone, here I share with you public health measures or milestones that were applied in association with community measures to curb the spread. So these are the public health and milestones, and there will be more talk about the community milestones as well. The first of it, April 17, there was a long-term care facility outbreak declaration. On April 18, with the link of the Northern Alberta outbreak, we issued a precautionary travel advisory recommending that people working in Northern Alberta, when they come to Loche, they self-isolate for 14 days. We also recommending against non-essential travel to Northern Alberta. On April 22 was operational surge, and this is based on certain parameters, epidemiological parameters and public health parameters.
Also on April 29, we established the Gene Expert. It goes live in Loche. So we had this rapid testing, which gave us also the advantage of getting enhanced testing and turnaround time in 1 or 2 hours. And finally, on May 10 to 20, we based on after our aggressive contact tracing, we find that we, in association with our counterpart in NITHA, we had strategically launched a door-to-door active case finding. So giving more information about the door-to-door active case finding, it is a local approach to combat the spread. It really took us extensive preparation of the community through daily communication. And this was through our communication with the community and community leadership through our interactive live radio communication translated in Dene, and also orientation and preparation of the deployed staff with the help of our local community outreach workers. We screened 813 houses in Loche and its surrounding area of Garson Lake, Black Point, and Deschamps Lake. The use of Gene Expert, as I mentioned, was very helpful to guide the active case finding and household risk assessment to support the vulnerable population. We applied the strategic testing strategy in collaboration with the provincial lab in Regina and the Gene Expert with a capacity of 35 to 50 tests threshold per day. We had the full support from the Managed Alcohol Program, Mental Health, Community Emergency Operations Center, and the actual time of the active case findings for door-to-door for Loche and its surrounding communities was from May 12 to May 20. Now, this is a common slide that I will share with you, with Dr. Ndbuka as well from NITHA. So this is active case by community, Loche and other communities, and Clearwater, on and off reserve. There is also Boval, Buffalo, English River, Patchinat, Isla Cross, and Jans Bay. So these are the area where we had our cases. If I talk about Loche here, you can see that we, for example, here with the timelines, the long-term care facility was at that time between 17 of April. The precautionary travel advisory was launched here. The operational surge and the asking for help when there was certain parameters with increasing cases, doubling of cases per at least 10% of 3 consecutive days in a context of substantial increase. And also there was, as you see here, the congregate facility is a long-term care facility, and also there was consideration of some complex cases, and there was started to have more unlinked chain of transmission in a 14-day period. So at this time, we will ask for help and from the Saskatchewan Health Authority, and we had this operational surge plan. On April 29, we started the Gene Expert, and you can see here the increase of cases, active case finding, and then there was on 12 May 2020, there was again some cases that were discovered by door-to-door finding. I will turn it to my colleague, Dr. Ndbuka.
Thank you, Dr. Zayed. As you can see from this slide, the index case in Clearwater River was reported on April 18th. The individual was a contact to a case in Loche. Through contact tracing investigation, additional cases who were also close contacts to the index case were identified in other communities. Given the connectedness between communities in the north, it was not surprising to see additional cases beyond one community. Travel restrictions, however, were put in place to prevent further transmission. Dr. Zayed will be presenting the next slide.
Thank you, Dr. Buka. So this slide just a very few put some incidents that have happened during the outbreak. So we have here it's divided by incidents or epidemiological links. So as you see, the largest one was related to Clear Lake. There was also the long-term care facility in conjunction with the Clear Lake incident. And then we had an incident in a neighboring community in the northwest in Beauval. So it was a Beauval store, and it is also linked to, in a way, to Loche. There was access, a problem, this highlighting the access of care problem when some people from Loche went to get renal dialysis. So we had these few cases also, and there was other cases related to RCMP. And again, all these are really stories and learning lessons. And there was an incident in a fire cache facility as well. So this certain exposure. And some of those have been unknown or not determined. Like this means not really not determined, but we couldn't have a specific link to these cases. Dr. Ndubuka?
Thank you, Dr. Zaid. To contain the COVID-19 infection in Clearwater River, NITHA worked closely with the Middle Lake Tribal Council, Indigenous Services Canada, the Saskatchewan Health Authority, and the Clearwater River Health Team. Mobile teams were deployed to implement voluntary mass testing as part of active case finding. A door-to-door and drive-through testing were employed between May 11th and May 22nd. Mobile teams of nurses performed risk health assessment, provided one-on-one education about COVID-19 to individuals, addressed their concerns, and also offered testing. And testing was offered regardless of symptoms. Community members who volunteered to test were offered the choice to test either in their home or at the community health center. As you can see from the slide, a total of 213 homes were visited during the period of door-to-door testing. 288 individuals were offered testing. Of those, almost half accepted. Majority were swabbed in their home. Positivity rate for the door-to-door testing intervention was at 1.4%. Of the individuals approached for testing, almost half declined. This might have been attributed to fear and stigma in terms of what a positive result would mean for the individual, for their family, and for the community at large. My colleague, Dr. Kaketla, will be presenting the next slide.
Thank you. Before we wrap up the introduction, I'm just going to chat very briefly about the use of mathematical modeling as an additional tool that helped to inform our response strategy. Through modeling, we were able to do a few things. One was support planning for human and infrastructure resources required for the response. We're also able to use it to better understand the individual and the cumulative impacts of specific interventions within our response. And we also found that it helped us in terms of supporting our knowledge translation, such as through our communications with communities about the risks of mass gatherings. We were very fortunate to have the tremendous expertise and support of Dr. Osgood, Dr. Bazran, and their team at the University of Saskatchewan's Computational Epi and Public Health Informatics Lab. We got together with them a bit earlier on once we started seeing our cases start to rise within the Loche and Clearwater area, just to do some focused work around this area. It was very important for them that they understood our specific context, the community dynamics, interactions between these specific communities and other surrounding communities, and particular nuances that could inform their modeling. We were able to work together as population health teams to provide them with specific variables such as housing characteristics, school locations and characteristics, access to health services, mobility patterns, testing data, and really any other information that was helpful for them to understand our descriptive epidemiology in terms of what they needed to inform their modeling scenarios. through that process, they were able to generate effective reproductive numbers for our area, an example of which is depicted on that slide. As a reminder, the effective reproductive number is the average number of people one person with the virus infects at a current time after at least some population has been affected or recovered, or after an intervention strategy has been implemented. And there are a number of assumptions that are also inputted into that model. At the peak of our outbreak, the effective reproductive number was about as high as 6, and we gradually saw a decrease to eventually less than 1, depicting the cumulative effect of the interventions described by my colleagues in previous slides. Jennifer, back to you.
Thank you, Dr. Keketla. Now we'd like to share some of our lessons learned through the outbreak. And I think one of our biggest learnings, or what worked well, was a strong collaborative partnership with the Saskatchewan Health Authority, Loche and Clearwater River Dene Nation community leadership, namely Chief St. Pierre, Leonard Montgrand, who is the MNS area director, as well as the Friendship Center executive director, and Chief Teddy Clark from the Clearwater River Dene Nation. Our medical health officers, Dr. Nabuka, Dr. Zayed, and Dr. Keketla, as well as Dr. Irving, were very key to this collaborative partnership as well, and the local EOC Emergency Operations Center. You know, we were able to run the health programs and the public health response, but really key to our approach was connecting with the leadership and the Emergency Operations Center to meet the needs of the community, and that was significant in terms of some of the intergenerational trauma or social determinants of health challenges we faced, and this team went above and beyond, delivering food, supplies to those in self-isolation, and just really being the eyes and ears on the ground in the community and making sure that the community members had the supports that they needed and the supplies as well. We also had strong partnerships with the Northern Intertribal Health Authority, support from the Saskatchewan Government Relations, Saskatchewan Public Safety Agency, the Northwest Regional Emergency Operations Center, which was comprised of the First Nations leadership, Métis leadership, as well as municipalities, all met daily on the Northwest Regional EOC, and that support was key as well, in addition to Indigenous Services Canada, our First Nations partners at Meadow Lake Tribal Council. The list could go on, but these were significant partners in the outbreak response. And with that, I'll turn it to Dr. Zayed.
Thank you, Jennifer. With regard to public health interventions, when we think what really worked well was mainly the public health order, mainly the travel advisory, the plan for community engagement and ongoing communication with the community in every step, and the community leadership, the assisted self-isolation help people who have some like issues related to addiction or dependency to continue their self-isolation. So that was also a great intervention and timely intervention. The enhanced testing, of course, reduced the turnaround time and help us to make good decisions. Contact tracing and case finding in collaboration with NITHA. So we were working together, following a specific strategy for testing and active case finding. Finally, through the implementation also for door-to-door screening and testing. And also the door-to-door screening was not only a screening for testing, but also was a risk assessment tool. Deployment of voluntary staff from across Saskatchewan was also an important part. Without it, we could never be able to curb this spread. So having a pool and supplementary workforce through the Saskatchewan Health Authority and this kind of organization was really very helpful. The ongoing communication day-to-day with the community members in English and Dene was very important. The people were waiting for the live radio talk, implementation for the managed alcohol program, and that was done in a very, very short time frame, and mobilizing all these efforts to get this done in a very short time was really key. And thanks to all the team who were working on that, the quick mobilization of logistics, and we had this daily check-in about our operations in a color-coded manner, where we have this green, yellow, and red. So this was also a very good way to know where are we from operations and logistics. And as my colleague mentioned, the modeling also very good guidance, and in addition also to the surveillance that we have in the population health unit. The flow of information between different stakeholders was very important and was very organized, and the financial support from the Métis Nation.
Mayor St. Pierre, not Chief. You're on.
That'd be cool too. Yeah, what worked well basically is the communication from health and leadership and the EOC and to the community, and to ensure that those pieces, all the pieces come together, we had to have checkpoints. And with the checkpoints, we needed the enforcement from the conservation officers, which the province provided, which was helpful. And then we had our curfews of 10 o'clock we started off with, and just to mitigate mobilization within the community. The closure of the liquor sales, which we could not have if we did not have our enforced checkpoints. So those are some fine things that you got to consider. The community engagement, once again, Dr. Zayed led to this, is communication always to the community on a timely fashion, and up-to-date factual information, that is. Strong community leadership, which is ourselves, and the rest of the EOC team, the weekly meetings that we had, we're all members of this community, and we all contributed to it, so that we needed to have that solidarity. There was no cookie-cutter approach to the pandemic response. We gave the facts, and the facts as harsh as may be, and we had to respond to the community in those manners. Multi-jurisdictional approach. Basically, we took out our borders. We said, no, this is our community. These are our people. Let's deal with them as such. And so, and the communication, of course, in our language, Dene language, was important, especially to reach the older generation. And we were culturally grounded, strength-based approach to public health measures, and working collaboratively with health on those fronts. So, Leonard, do you have anything to add? This is your time. Go ahead, Leonard.
There, I'm off mute. Just a couple of things we had concerns with in terms of dealing with COVID. We did have the issues of the Privacy Act that we had to deal with, which was very frustrating to us. It's understandable as we progressed through it. We learned a lot from the health authority. We did, in terms of, and at times we butted heads because we felt that their approach wasn't the right approach, because we wanted to do a community approach, but we understood at the end of the day that they were they were proficient in what they were doing. The other thing that concerned us, I think, as a community, we had a lot of things were thrown at us at once. The curb payment that went out to a lot of people in the community did affect the transmission of the COVID, because it created an influx of cash within the community, and the cash was then distributed around, increased the mobilization of people within the community. So that was a concern. But I mean, this is like a proactive report that we're giving you folks. It's kind of like a, how can I say it? It's like something like a report card for school. We want to make things better. We don't want them to repeat. We want to ensure that next time, the next wave, when it's coming, we know it might never leave our community. It might be a continuous wave, but that we're working towards alleviating the symptoms. Thank you.
Thank you, Leonard, Mayor St. Pierre. I think that's a good segue to what would be even better if, or what were some improvement lessons we learned through the COVID outbreak. And one of them was At the outset, support for vulnerable populations and assisted self-isolation was lacking. I saw a question in the chat box about the assisted self-isolation, and I'll speak a little bit about it, but because of the social determinants of health and some of the challenges that Brian Quinn had spoken to earlier, overcrowding was of significant concern. Often we'd see multi-generational houses with grandparents, parents, children, potentially grandchildren, all living under one roof. So it was very difficult to self-isolate in a home if you were COVID positive or a close contact. So one of our quickly learned lessons is we needed alternatives, and because there was no hotels available and very limited housing available in the community, we had to come up with some innovative approaches. So with support from the local EOC, the Saskatchewan Public Safety Agency and the Métis Nation of Saskatchewan provided trailers and RVs that were parked by the local EOC, and were the Métis Nation of Saskatchewan hired security to monitor those sites, as well with the support of the RCMP sometimes when there was a non-compliant community member who was COVID positive. And, you know, part of our lesson there was if you don't have a roof over your head, or you have addictions issues, it's really challenging to care about COVID or the transmission of COVID. So had to come up with some of those innovative solutions, and in partnership with the community and the agencies. So in some of those respects, those COVID positives that were non-compliant with public health orders were held in assisted self-isolation, it's referred to, and they were provided with meals. The managed alcohol program also provided pours in the assisted self-isolation units for those that were challenged with alcoholism or addictions, and it assisted them in staying in self-isolation, but required a 24/7 approach with the local EOC, the leadership, the health team, as well as the RCMP and the Saskatchewan Public Safety Agency. So it certainly was not an easy task, and challenging in terms of some of them needed enhanced supports, and mental health and addictions would provide counseling, or again, the managed alcohol program would deliver to those units. Another challenge was the lack of available PPE, hand sanitizer, and disinfectants for community members. This was not unique to Loche or Clearwater, as you guys are aware of. It was a worldwide, there was a worldwide shortage, and continues to be a challenge. But because of a number of donations from different areas, mining companies, the Métis Nation of Saskatchewan purchasing some of those much needed supplies was key as well. If you don't have the financial resources to purchase disinfectants or to self-isolate effectively, we're only going to see that spread continue until a vaccine is developed. So I think those were really important as well to containment, but certainly challenging. And at the outset of the outbreak, there was some communication gaps because there was so many people involved in multiple agencies, but it definitely improved throughout the process. And you know, there's very little known about COVID-19 again, and it created a lot of fear and anxiety in the community. People just weren't aware of kind of what COVID-19 and the implications were, and there was a lot of fear related to the media coverage and the stories that they were hearing, so that was a concern as well. Dr. Zayed?
Thank you, Jennifer. So one of the main challenge really is the retaining of healthcare workers and the limited capacity we have in different areas. So investing in local community capacity building is really an important thing for limited human resource. Also, the innovative solution to chronic problems. So we were faced with some chronic problems related to social determinants of health. So again, during this crisis, we were trying to get, as Jennifer and all other my colleagues and Mayor St. Pierre were saying, we were trying to get some solutions. It's a temporary solution for chronic problems, so that was really challenging. Addressing the stigma, so the stigma is a compound word and or term that was in that time was related to uncertainty, fear, and anxiety, the unknown, in addition to people who are sick and what they can do. And so again, this also was, as my colleague Dr. Ndibuka said, was sometimes a deter against getting tested or getting isolated. So that was also this is a pronounced issue or concept that was very existing with the COVID-19. Also, the lack of infrastructures, as mentioned by Jennifer, there was no hotel, for example, we needed help, and we get some health care provider from other parts of the province, but there was no hotel to accommodate or places to accommodate them. So again, we needed a lot of planning in a very short time.
Yeah, and I think that was key as well, was the SHA EOC and the Integrated Health Command Centers, as well as the SHA Labor Pool and HR helped us get additional staff to respond to the outbreak in the Loche, and that involved over, I think, 60 staff from across Saskatchewan, and we wouldn't have been able to complete the enhanced contact tracing or testing as well as mobile door-to-door without those additional resources. So it was important, but it created a lot of challenges for us because of the lack of housing or hoteling. People had to commute from Buffalo Narrows, which is approximately an hour away from La Loche, simply because there was no ability to house them in the community, and that was exceedingly challenging. And I also see one easy question there I'll just give a quick answer to, Donna. With little known about COVID is we worked with the SHA to develop kind of COVID fact sheets or information from communications, our communications department, as well as the First Nations and Métis unit at the SHA provided the translation from English to Dene for all of those materials as well. Deputy Mayor Randy Herman was so key. As you heard, we did daily updates on the radio in English and in Dene, and so as you saw in the presentation, there's a high number of Dene Sulani speakers in the area, so it was important, especially to reach the vulnerable group, or the elder group, who primarily only speak Dene, so those were really important steps as well. Robert?
Yes. Was there a specific question?
You were going to speak to the challenges?
Okay. Yeah. Well, stigma and discrimination. I was just reading some of these questions here. That's why I got tied up. Stigma and discrimination, just the lack of understanding or the fear associated with unknown, right? And when the realization set into the community that COVID hit home, and we've had a couple deaths so far, all that created quite the anxiety. And I think the message from the leadership and from health was always constant, and that at the end of the day proved to be our ally when we had those factual information. So social determinants of Indigenous health had a major impact on the pandemic. So we had, look, we have a lot of challenges in our community, but because we knew what our challenges were, and health and the leadership working together, we're able to combat a lot of these, to be responsive and be effective. And the contact tracing with the extra resources coming into the community certainly helped, especially when it comes to the door-to-door with all the measures put in place. Everything just came together, and it was a timely way, and the constant messaging from the leadership and health really proved to be what made an impact, I think, on our resolve. Thanks.
This is Leonard Montgrand. I just wanted to add a couple of things to that. When we speak in terms of infrastructure, our community is a population base of around 3,000 people. We lack the basic amenities that most communities have. Even smaller communities with a population base like Buffalo Narrows They have a population base of about 1,200 people. They have 2 hotels. They have restaurants. They have all these basic amenities that most communities take for granted. We don't have them. When we had the school shooting in Loche over 4 years ago, Minister Bennett came into our community, and she seen that we were in desperate need of infrastructure. She gave us the money to build our new Friendship Center. And today our Friendship Center, our kitchen is being utilized 24/7 to provide meals for isolation units for people with that are Meals on Wheels that are isolated in their homes. And also we provide meals to our homeless shelter. And these are all grant dollars that flow in. So when the grant dollars are gone, what do? We revert back to the community of old, and we don't really have any ability to make changes. That's the main thing. I stress that a lot, is capacity and infrastructure. Without it, we can't move forward. If we didn't have a Friendship Center, I don't know where we would have turned to, in honesty, to be able to maintain status quo. Thank you.
Dr. Zayan?
Yes, thank you, Jennifer. So this is like to conclude our story today. So what's next and what is our next step? So COVID-19 crisis has created this opportunity. It's like a virtue in disguise, if I can say, to identify gaps and areas of improvement. A task force initiative is being proposed where all the stakeholders can collaboratively work together to achieve a sustained community well-being and engagement. So the successful effort in identifying and help to curb the spread of COVID-19 in the area was not also only because of enhanced testing, but by working so closely with the community leaders for this unprecedented initiative. We believe that a new level of trust has been built, which will have benefits in the future as the group work together to achieve better health outcomes for the residents of La Loche, where the community is the driver. Thank you.
Thank you for your patience. I know we went a little bit over time, but there's just so much to pack in and lessons learned, and we're very passionate about the work we do, our team. So thank you for that, and we're looking forward to answering some questions.
Well, thank you very much, Jennifer, and to all of the panelists for, quite frankly, a super informative presentation. It's really obvious. It's such a true community response to a pretty complex issue with so many facets. You had engaged comprehensive communication, your volunteers, just wonderful to hear about how you approached this particular situation in your community. So just a reminder to the folks who are participating, if you haven't already done so, please take a moment to type your questions into the chat, and we have just about 15 minutes left together so we can answer some of the questions that have already started to come in. Jennifer, you were super skilled and you were able to pick up on some of them already, but maybe we'll start with one of the first questions that came in from Elizabeth Cote-Boileau from the HSO. She's asked about cultural safety and how that was addressed in your COVID-19 outbreak response strategy. So Jennifer, I wonder if you want to take it, and perhaps then you could call on other members of the panel, or if there are other members of the panel who would like to respond as well, please just enter that into the chat and we'll open up your line.
I will take a crack at it. Probably my colleagues will have a much better response than I, but I think it's really clear through our presentation that in terms of cultural safety, we really worked with the community leadership, community members, and our local outreach workers are really key to relaying to us the reality of the community, the social norms so that we could have a good understanding of kind of some of the, we did talk a lot about some of those challenges around the social determinants of health, but I think a lot of times we overlook all of the strengths. Loche specifically and Clearwater have just been through a number of challenges. You heard Leonard speak of the school shootings about 4 years ago as well. It just dates back to colonization and the whole residential experience and the challenges that the community continues to face. But there's so many strengths and so many good people in that community that were teachers to the health providers, not just our regular team on the ground. There's a lot of local employees who were key in this ongoing teaching and education for our SHA staff, and also the deployed staff who were coming from across Saskatchewan. They could have been from Swift Current or Regina, Saskatoon, and the community was just so welcoming and open to teaching and showing the many positive things, even though we often focus on the challenges, and providing those services in partnership with the community leadership and driving that process and identifying some of the innovative ways that we could respond in a culturally safe manner or approach. And I think a small example of that would be the language barrier. Oftentimes when First Nations or Indigenous people access services and English isn't their first language, it's very challenging because sometimes you don't know if they've learned from their appointment visit because they don't have English as a first language. And that was taken into consideration at the outset by the community leadership, that we needed to provide COVID information, timely updated COVID information based on best practice, but translated into the Dene language. And with that, I'll hold and see if anybody else wanted to add to that.
Yeah, I can add to Dr. here. Yeah, I think Jenny, for the response. I think for just speaking from the Clearwater aspect, I think putting the community into perspective in all aspects of the planning was really very helpful in terms of ensuring that some of the interventions were really tailored to the community. Like Mayor mentioned earlier, that there is no cookie-cutter approach to pandemic response. So what worked elsewhere might not necessarily work in one particular community. But one of the things that we actually did was that the mobile teams really had community health nurses who were residents of the community to lead those teams, so that the community residents will have some bit of comfort and recognition, and also to address the language barrier that might have been a challenge. So recognizing that there were many nurses that were mobilized across the province to support these two communities, at the end of the day, those that were residents there were really the ones that actually provided any direct connection when it comes to addressing language barrier, and also some of the cultural safety components, which we saw was really supportive of the success that we saw in the communities. Thank you.
I want to add one small thing as well to that, to what my colleagues have said. The door-to-door mobilization, active case finding, where also we had consulted with the community before, so the community were well prepared for this. Also, the healthcare workers coming from the south, they had some orientation and help from the community outreach workers from the local community, who knows everyone living there like the back of their hands. So this was also a very important thing. In addition to that, how the community at that time was welcoming this help, and they feel really at home. So this is very important to have this kind of community interaction all the time, and also the transparency and the consultation with the community in every step.
So just this is Leonard, sorry, just to add to the culture piece. As Dene people, our language is our culture. That's basically all that we have. We don't have cultural knowledge of past. I mean, we've tried to bring it in the community. Just to give it to you in context, the Dene people, we used to live in the middle of the province, and the Cree and the Dene used to fierce enemies. Some of the Dene fled to the south. Geronimo was a Dene person. The other Dene people fled to the north. So when those separations became part, we lost some of our cultural identity. And as we progressed forward, I myself am a residential school survivor. My father was a residential school survivor. We've lost our cultural practices. The language is the only thing that we really have left culturally. So we try to inundate new methods of learning our culture, trying to practice and believe in our new identity as Métis people or as First Nations people. But as far as culture, language is predominantly the strongest tie we have in our community. Over 80% of our people in our community speak Dene as a first language. So that creates a barrier at times. And that's what we tell people when they come into our community, come and learn about our community. They have to be respectful of that language barrier. They have to try to work around it. And at times it works out very well. Thank you.
Thank you so much for such a good reminder about the impact of culture and language. And thank you so much to Jennifer for reminding us about, that there are strengths to be built upon. We have only probably time for not a whole lot left, and there are lots of questions in the chat. So I do want to just remind people that within the week we will follow up with the recording and a summary of today's discussions and links to resources, and they'll be posted on our website. But I'm wondering if we might have time for one last question. And Jennifer, again, I'll call on you, but ask that you perhaps direct us to the most appropriate person. I wonder if you can speak to how far in advance of the outbreak were your pandemic plans for COVID prepared?
This is a tough one for me. I'm sorry. Oh, go ahead.
Okay.
Yeah. So, like I said, with the beginning of March, or the second week of March, we decided that we needed to develop a pandemic plan. And we know our community, so we need to get key players throughout the community. We have Leonard, who's the director of the Friendship Center and area director for the Métis Nation. We have Chief Teddy Clark from the Reserve. We have his workers, Janelle Cogan and the Clearwater River Dene School, the principal, vice principal, and such. And we had our schools, and we had the Friendship Center, we had the businesses. We all come together, and we all developed a plan based on what we have. We know what our existing is. So based on that, we were able to come up with a plan that we thought would work. The only thing that was lacking was the provincial commitment for municipalities, for myself as mayor, to be able to carry out some of these directives. But thank goodness we had the Métis Nation Saskatchewan and the First Nations that we were partnership with, who were able to finance some of these costs, because there's a lot of costs associated when you're coming up with plans, especially with checkpoints, with security, with having the personnel, having the EOC. And we were able to probably do a better job had we had the response from the province at an earlier stage. However, they did come in, but they did come in later on. But that was very significant in having that foresight and for leadership to come together in partnership and develop that EOC pandemic plan. And I think we were one of the first communities to have a pandemic plan. Go ahead, Jennifer.
And in terms of the in terms of the SHA, they built on previous, I think, plans. I'm sorry, I'm just pulling up the information. There's some really good questions here. They built on existing plans, and so because the outbreak hit so quickly in our area, we were planning as we were implementing as well, so that was one of the challenges. But I know in terms of the SHA that planning began in late 2019 on those existing pandemics, and then we had to respond accordingly to amend those plans to be able to respond to COVID. Thank you.
Thanks very much, Jennifer. We're just about at time, so I think I'll pause our question and answer period at this point, but we will aim to follow up, Jennifer, with yourself and the other members of the panel to get some answers to the questions that have been posed. Lots and lots of interest and so much that could be discussed here today. And as I said, we will prepare a summary of today's discussions to share with the participants. So thank you to all of our presenters and the organizations and the people involved, and thank you to our participants. Your feedback is invaluable to us. It helps us with future websites or future webinars. So I'd ask that you stay on the line for just a moment to provide us with some feedback on today's session and complete a couple of polls for us. So once again, my deepest thanks to our presenters and the members of our panel, and also to our team here at CFHI and for those working behind the scenes. Thank you so much. This concludes today's webinar.